Welcome to this explainer. Today, we're diving straight into the chemistry, the anatomy, and the incredible surgical precision that makes local dental anesthesia possible. Because honestly, beneath the surface of what just feels like a simple pinch, there is this massive, complex world of pharmacology and neurology. And we are going to explore exactly how clinicians manage to safely hit pause on human pain. So here is our quick roadmap for today. Part 1, the science of numbness. Part 2, how long does it last? Part 3, advanced mandibular techniques. And Part 4, when things go wrong. Now, we've all been there, right? Trying to drink a hot coffee with a totally numb lip hours after a procedure. But the physiological reason behind that lingering sensation isn't just an annoyance. It's actually a direct result of how highly specialized drug profiles interact with your vascular system. And to really understand why this happens, we've got to look at the chemistry. Which brings us to Part 1, the science of numbness, anesthetic agents and their facial targets. Think about it like this. These chemical agents, mostly amides and esters, literally pull the plug on electrical pain signals before they ever have a chance to reach your brain. By permeating the nerve membrane and blocking the sodium channels, the signal is physically stopped in its tracks. If the electrical pulse can't travel up the nerve trunk, your brain simply does not register the pain. But importantly, not all of these chemical agents are created equal. What's really wild is the sheer difference in duration based on the exact drug selected. Lidocaine is your industry standard. It gives you a solid 3 to 5 hours of soft tissue numbness, which is perfect for routine filling. Articaine bumps that up a bit, but its real superpower is its unique molecular shape, which gives it superior penetration through dense bone. And then we have bupivacaine. This agent is an absolute powerhouse, giving patients up to half a day, 12 full hours of natural postoperative pain relief. And that drastically cuts down a patient's need for painkillers after a complex surgery. But of course, clinicians can't just use as much as they want. There's a hard limit. 3 milligrams per kilogram of body weight is the safe maximum dose for standard lidocaine without adrenaline. Dentists have to constantly calculate the exact volume needed to kill the pain while making absolutely sure they stay safely within the metabolic limits of a patient's specific body mass. Okay, let's shift gears to Part 2. How long does it last? The clock and physiological variables. You see, it is not just the drug doing all the heavy lifting. Your own body's mechanics play a massive role in clearing out the anesthetic. Because most modern local anesthetics are metabolized in your liver, your hepatic function directly impacts how long you stay numb. Similarly, kids naturally have higher metabolic rates, so they typically process and clear out the anesthetic much faster than adults do. But the most significant local factor of all, the chemical state of the tissue itself. This brilliantly illustrates why numbing an acutely infected tooth is notoriously difficult. The inflamed tissue around the infection is highly acidic. That acidity essentially neutralizes the anesthetic before it can even penetrate the nerve membrane. When that happens, clinicians sometimes have to rely on advanced buffered solutions or just use completely different injection strategies altogether. Anatomical density also changes the game entirely. The maxilla, your upper jaw, has a really rich blood supply and relatively porous bone, which means it clears the drug out pretty quickly. But your mandible's dense bone basically traps the anesthetic in place. When you combine that dense bone with the fact that clinicians are blocking a massive nerve trunk, that lower lip is going to stay numb for a good 1 to 2 hours longer than the upper jaw. That takes us to Part 3, advanced mandibular techniques, overcoming anatomical limitations. Take the mental nerve block as a really elegant alternative. If a patient only needs work done on their front teeth, freezing the entire tongue and the back of their throat is totally overkill. Instead, clinicians use these precise, targeted steps to hit the mental foramen, which is the exact exit point of the nerve on the front of the jaw, achieving a perfectly isolated numbness. But what happens when profound numbness just completely fails? Dentists have to deploy advanced techniques. The Gow-Gates approach requires a wide open mouth to reach the nerve way up at the neck of the condyle, and it boasts an impressive success rate of over 95%. On the flip side, you have the Vazirani-Akinosi technique. This was specifically designed to bypass limited jaw mobility, also known as trismus, allowing the needle to advance safely through the soft tissue while the patient's teeth are completely clenched shut. And finally, Part 4, when things go wrong, complications and clinical mysteries. Now, thanks to modern, sterile, single-use equipment, severe complications are incredibly rare. However, understanding the potential risks is vital. These can range from localized hematomas caused by an accidentally nicked blood vessel all the way to transient facial nerve paralysis, where a patient temporarily, literally cannot blink an eye. Having this baseline awareness is crucial before we examine a true worst-case scenario. To really put the stakes into perspective, let's look at a gripping, real-world medical mystery from a clinical case report. A 38-year-old male patient was referred to an oral and maxillofacial surgery unit. During a totally routine attempt to numb his lower right jaw for a molar extraction, he experienced a sudden, sharp pain, and he flinched. That sudden movement caused the dental needle to fracture inside his mouth. And the fragment? It was completely lost. 3 days after this failed block, the guy shows up at the hospital in absolute agony. The trauma to his local muscles had caused severe trismus. To give you some context, a normal mouth opening is around 40 to 50 millimeters. This patient presented with a severely restricted mouth opening of just 13 millimeters. That is barely half an inch. And the needle fragment was totally invisible to the naked eye. A 3D CT scan was ordered, and it immediately revealed just how high the stakes were. A 2.1 centimeter piece of sharp metal was buried deep within the right medial pterygoid. Now, this is a highly active chewing muscle, located deep inside the jaw, and it is surrounded by a dense web of critical nerves and blood vessels. Leaving it there absolutely wasn't an option. Under general anesthesia, the surgical team had to execute an incredibly complex retrieval. Raising a large tissue flap, they had to actively hunt for, and then very gently retract the lingual and inferior alveolar nerves, to make sure the patient wouldn't lose permanent sensation in his face. Utilizing a C-arm X-ray machine in real time, they carefully navigated past these major sensory pathways, performed a precise blunt dissection, successfully extracted the metal fragment, and cauterized the bleeding. Thankfully, the patient made a swift and full recovery. As we wrap up this explainer, I really want to leave you with a thought. The human face is this fragile, beautifully complex anatomical landscape, completely packed with vital structures. The fact that we have mastered the pharmacology and the spatial awareness to routinely navigate this maze, comfortably shutting off the body's pain alarm whenever we need to, is just a staggering scientific achievement. Keep learning, keep exploring, and we'll see you in the next explainer.